presenting in clinical nuclear cardiology of beyond stress perfusion imaging. I believe some of the speakers are prior to me have talked about certain aspects of it, which of course I shall not cover. I shall try to cover other things that they may not have, and I apologize for not listening into the other studies because of the time difference. There's a, I would not have been able to sleep. Nevertheless, it's early in the morning here, and I'm happy to present, and I have no disclosures at this in this talk. Although, as far as the U.S. is concerned, I will talk about things that are not necessarily FDA approved or reimbursed over here by CMS, but it may be done at other places outside the U.S. So when we really look at cardiac parameters, we want to look at what's come in the past and what's in the future. And some of those things that are been done in the past are still relevant. For example, MUGA has been one, is a study that's somewhat oft forgotten. It has, in many cases, rightfully been replaced by echocardiograms. But nevertheless, it's important to realize, what did it do? We could do first pass evaluation for right ventricular function, look at left to right shunting. We could do equilibrium imaging for left ventricular evaluation. Look at diastolic heart failure. Now, remember, this is decades ago. This is about, 40 years ago. We could just look at that. Whereas it was more a curiosity then. In the last 20 years, diastolic heart failure has become much more clinically important. So MUGA was able to do that several decades ago. And now there's also SPECT imaging in MUGA. However, if we were to look at right to left shunting, that's actually quite a different scan. We can talk about that briefly. And then the newer developments in fatty acid metabolism imaging and neurohumoral imaging are quite important. And I believe previous speakers would have talked about amyloidosis and viability, which I will not be touching upon. So MUGA is, despite everything, despite the advances in clinical echo, MUGA remains the gold standard for accurate assessment for left ventricular ejection fraction and function. And the reason for that is it has less inter-observer variability. It is more reproducible and repeatable than echocardiograms. That means you could do serial echoes, or have the different readers look at the echoes and get more variability in echo reads than you would get with MUGA reads. Nevertheless, it is much more labor intensive than echo. It is more costly and has ionizing radiation, which echo does not use. And its uses for MUGA currently are, when you get equivocal echocardiographic results, if the cardiologist is astute enough, they should be referring patients for MUGAs. Sometimes you see changes in echo that, could make a major clinical change in management. And to confirm those findings, you could do it with MUGA. In morbidly obese patients or women with large breasts, it can certainly be an issue trying to get through soft tissue, and MUGA would be better for that. But nowadays, if it is used, it's also used for following up cardiotoxic therapies. Sometimes you do it in shunt analysis in pediatric patients, but RVEF, and there are some newer approaches I'll be touching upon. So when we talk about planar RVEF assessment, it is a flow procedure. You basically inject as a bolus. And the good thing is that you can catch the RV in isolation, because when you have the LV blood pool come in, then there's overlap between the two, and that can obscure your ability to do an RV evaluation. The problem, of course, is that arrhythmias can invalidate the first pass study, because this is a gated study according to the ECG of the patient. That being said, there's no reason why a first pass RVEF cannot be done on just stress perfusion imaging. If you inject the patient underneath the camera at the time of injection, you could do a first pass analysis. And for that matter, if you're doing PET, you could do a dynamic PET analysis just as the patient's being injected. So you don't necessarily need to have a separate MUGA. You can do a lot of these procedures right into the camera, doing other procedures that you usually do. So looking at left to right shunt studies, this is almost completely replaced by echo. And this is done with tagged RBC scans. And what we look at is recirculation time activity curves as the first pass is going through, because it's very difficult to visually assess what may be a shunt based on what the images show you. But again, like I said, you could similarly do a first pass analysis for SPECT perfusion studies or with PET. And in PET, of course, you're getting it in 3D, which is even better. So, these are methodologies that have been tried and proven, and you could be using them. This is shows you how a study would be done. For example, you can see there's a bolus that's going through, gets into the RV, and slowly gets into the outflow tract as we go along. You can see the lungs start getting blood pool activity. And here you'll notice that's where the LV is supposed to be. LV, of course, hasn't filled yet because it's still making its way through the lungs. But later in the study, you can see LV start showing up. Eventually, you start seeing it starts leaving the lungs, getting through the blood in the cardiac blood pool, getting into the aorta, and finally into the viscera. And finally, what happens is the blood spreads all over the body in the blood pool, and it starts equilibrating, and you can then get into the equilibrium phase. But nevertheless, if you look at draw regions of interest over the pulmonary flow and the systemic flow, you can come up with these curves. And based on these curves and times of appearance of these peaks, you can create a shunt ratio and therefore a shunt analysis of how much shunting is taking place and potentially to some extent where the shunt is. Some of you may recognize this because these are the type of curves that are generated when patients undergo catheterization and they do thermodilution studies to look at for shunting. And again, the concept is virtually identical. Of course, the difference is that MUGA is non-invasive, whereas catheterization is, of course, invasive. So as I mentioned, when we do LVEF studies these days, we're really looking at cardiotoxic toxicity and type therapies. And for example, doxorubicin was a classic drug. It was a toxic chemotherapy drug. And there have been algorithms that have been established where you would do a baseline study and then do it at various, after the patient's got various drug levels, you would repeat the MUGA study. Or to be cost effective, if the patient remains asymptomatic, no evidence of heart failure, you could do it at baseline and do it when you've gotten relatively higher doses of drug. And then also there's a clinical decision-making algorithm with regards to, how much of a change do you want to tolerate before you want to go and assess or maybe even stop the patient's drug, or if the patient's already got baseline heart failure, when should you be doing the MUGA? So these algorithms have been there, but again, they're mostly replaced by echo. And doxorubicin, of course, is not being used as much as it has been in the past because of the presence of newer immunotherapies that have come up, bioimmunotherapies. But even with the bioimmunotherapies, there are certain algorithms because some of them are somewhat cardiotoxic. So by the same token, there are algorithms of potentially when to repeat the MUGA studies and, if there are symptoms or not. But again, in most institutions, this is done by echo. And as I mentioned earlier, I think that is fine. If there's stability or slow changes, that's okay. But whenever there's the echo is showing something with changes management, it is my belief that MUGA should be done at that time to confirm the findings. So some of the other parameters I mentioned, you could look at time activity curves of the equilibrium images to look at diastolic heart failure. I won't go into that. I want to talk more about dyssynchrony and optimizing biventricular pacing evaluation. Why is that important in MUGAs? Because biventricular pacing has become more and more of an issue because there are an increasing number of patients with pacemakers. And a lot of times it's a result of a chronic heart failure. A lot of times that's due to ischemic heart disease. And as a result, patients have mechanical dyssynchrony in the way their ventricles are contracting. And if you do not have good synchronized ventricles, you can have overall poor function of the patient, and overall prognosis has also been shown to be poor in those cases. So if you can correct those aberrant contractions with biventricular pacing leads, which therefore leads to improvement in the EF and potentially also patient outcomes. So just as an example, here's a patient with you're looking at phase diagrams, which basically looks at the motion of the ventricles and say where are the areas of the peak, and also what are the phases of the various parts of the ventricle. And you really want to have everything peaked kind of in a narrow area together. You don't want to see these spread out curves that we're seeing in the LV. So most of it are peaking at one area, but they are kind of spread out. Now, after appropriate placement of biventricular leads, you can see what happens is that the areas, the contraction, the synchrony analysis shows that there is a better peaking and better phase motion of the ventricles, or both on the right side and the left side. And so this is, so even though this looks broader in the center, because you don't see this wide dispersion across the ventricle, this is actually an improvement in the patient's overall function. So this is a successful placement of leads and outcomes. This, on the other hand, shows where a case where this didn't work. For example, you do see a little bit of dispersion, but you see most of it come to, centered around a line. But here it disperses more after lead placement, both on the left side and right side and left side. And these, of course, now are worse. So the leads would have to be changed in location to get a better phase analysis. And of course, moving from planar MUGAs to SPECT MUGAs, there are certain advantages, of course, because this is an equilibrium scan and you don't have to do a first pass. You can do LVEF and RVEF analysis simultaneously. And you don't need to do first pass for RVF. And if you're doing multi-planar studies of the MUGA, you might as well do you can do a SPECT because you get similar time of acquisition as the planar studies. You can avoid atrial and ventricular overlaps. But the problem is that the repeatability and reproducibility, which is what the key hallmark of MUGA is, has not been demonstrated with SPECT as yet. So, you're back to echo-like numbers, which is not desirable, because then you might as well do an echo. And it becomes a little bit difficult to combine first pass, which for shunting, if you wanted to do that. Now, you could do it, but your tracer tagging of red blood cells is not as efficient if you want to do the first pass, because if you do it with efficient labeling, which is completely in vitro labeling, then you really can't, you can't get a good bolus, because there's a fair amount of volume that you have to give back to the patient. There's also variability in the software. There's lower temporal resolution. For example, planars, you can do 16 to 32 frames per R-to-R interval. Whereas in SPECT, because of the fewer counts you get, you're more restricted to 8 to 16 frames per interval. Nevertheless, does that make a big clinical difference? Maybe not, but you do get that poorer temporal resolution. And of course, one of the big problems is that RVF of SPECT has poor correlation with the first pass RVEF. And of course, we don't really have a gold standard, and nothing's been actually looked at properly as to which one is actually a better method. So you can have two discordant values and not really sure which ones you should be reporting. So this is a demonstration of a patient with a planar MUGA scan, as well as a SPECT MUGA, what that may look like. And again, you can see the ease of analysis of looking at the RVEF in this case. The planar MUGAs actually do look better than what you can probably see here, but they themselves, you can do a good LVEF analysis, but not so much an RVEF analysis because of the overlap of the various chambers of the heart. And again, as I emphasized and mentioned, all this can be done with flow studies using PET. So if you do initial flow study of PET, you could potentially you don't need to do MUGA if you have a PET in the department and access to, say, a rubidium generator or whatever PET agent have you. You could do a first pass RVEF and all these parameters with PET, which you don't necessarily need to do with MUGA. Now, right to left shunting is a little bit different because here you want to look at shunting that goes in extrapulmonary vasculature. So you want to use macroaggregated albumin, which will get trapped in the pulmonary capillaries. And of course, this is what we use for VQ scanning. And therefore, you want to assess for extrapulmonary uptake, because if there is a right to left shunt, it's going to get past the capillaries and into the rest of the body. And when it does do so, you can quantify the shunting based on a whole body scan. And again, a lot of this has been replaced by echo, by bubble studies. But again, if you want to get a global assessment of the percent shunting, then certainly this is a useful study, particularly in pediatric patients. And this is an example of how a shunting study may look like, where you get the majority of uptake in the lungs. But again, if you do have right to left shunting, it'll bypass the lungs and go get trapped in the capillaries of the brain and kidneys and what have you. And you can take a big region of interest around the whole body to see what the counts are and compare it to the lung counts, and that can give you your shunting. Now, you are in essence embolizing the brain, but again, the number of particles is very small, so you're likely not going to make a big difference. But again, keeping those particle numbers small when you're potentially looking at these studies is key to doing these procedures safely. And now we're going to move on to some more modern approaches in cardiovascular imaging, where fatty acid metabolism is a growing area of research with the